Everybody to our this is our first Roybal guest speaker of the 2022. We have an excellent speaker named Josephine Särnholm, who I'll let her introduce herself a little bit more in a minute. But the big news is, as of yesterday, we were able to let her know that she's going to be the recipient of one of our Roybal Pilot Awards for 2022. And so we're really excited to hear about some of the work she's done already and the work that is going to be coming in the future related to developing exposure-based therapies for cardiac patients. A lot of her work is really consistent with the model we've been applying in our Roybal Center, which is thinking about the heightened distress patients have related to their sort of internal bodily signals, and we call it interoception, and how that can lead to a sort of pattern of avoidance, leading to suboptimal health behaviors in our cardiac patients. So with that very brief intro, I'm going to pass the baton to Josephine.
Thank you so much, Dr. Kronish, and I'm so happy to be here and for the opportunity to talk about my previous research. And I'm also very happy and grateful to have received the news of an opportunity to collaborate with you. I've been following your work, and it's an inspiration for me and my group, who are kind of an isolated island in Karolinska Institute working on cardiac psychology. So we're very eager to collaborate. Well, I'm a clinical psychologist by profession, and I defended my thesis on CBT for atrial fibrillation in June of last year. So I'm a recent PhD. And I'll give you a brief background of CBT for atrial fibrillation and how we developed the treatment program. And a little bit about what me and my group are working on right now. Please feel free to interrupt if you have any questions, so on. But to give you a context, I work at Karolinska Institutet, which is Sweden's largest medical university. And these studies were conducted in collaboration with Karolinska University Hospital. Down to the left, you see our snowy campus and the proximity between our aula, where we have our big events, and the hospitals. We just have a small bridge over, which creates a great milieu for clinical studies and interdisciplinary collaborations. And here's just a fancy picture of Stockholm, if anyone would like to come and visit our research group. I'll also give some credit to the advisor of my doctoral project and my research group. So these studies were carried out in an interdisciplinary collaboration between CBT researchers and arrhythmia specialists. So we needed a team of cardiologists, psychologists, one psychiatrist, a cardiac nurse to figure out how to best develop CBT for this patient group. And that's been wonderful learning experience to work interdisciplinary. But before I go into the studies and the treatment, and some of you might know more about cardiac arrhythmia than I as a clinical psychologist do, but it's always good to give a brief background. So atrial fibrillation is one of the most common cardiac arrhythmia. It's affecting about 3 to 4% of the adult population. It has a well-defined pathophysiological cause, and it's caused by faulty electrical signaling in the upper chambers of the heart, creating a chaotic and rapid electrical activity. And when patients have an onset of an AF episode, they experience a wide range of symptoms, such as palpitations, shortness of breath, weakness, chest pain, and dizziness. And oftentimes these episodes have a sudden onset and then can last for a couple of minutes or even for days. AF is a chronic disease, which means that chronic and progressive, which means that the episodes often becomes more frequent and long-standing with time. And my doctoral project and the CBT we developed pertains to patients with intermittent AF, also called paroxysmal. They have shown to have more distress because of the sudden interruption of life and sudden onset of symptoms. So AF is associated with poor quality of life and high rates of hospitalization and healthcare utilization. Psychological factors are known to affect the clinical course, and patients both perceive their symptoms as more distressing and severe if they also have concurrent depression or anxiety disorder, and it's also associated with more healthcare seeking. And as of today, there's limited effectiveness of current treatment options, pharmacological therapies or invasive procedures. And for a large proportion of patients, their disability and symptom persist. So there is a clear need for additional strategies to help these patients cope with their symptoms. So to further highlight the psychological factors that may affect the clinical course in the AF, I will present a brief case example, patients that we commonly see in our studies. So this is John, he's 58, and he was diagnosed with AF for about 3 years ago. He is on optimal medical care, and he has also undergone one invasive procedure. But despite his medical treatment, he still has about 2 episodes per month. And in between the episodes, he's very hypervigilant on his heart. He has persistent fear and worry to trigger any bodily symptoms or AF episodes. He has stopped physical activity or holding presentations at work for fear of triggering stress and increase his heart rate. He has also stopped playing soccer with his daughters, and he's frequently checking his pulse. And he's also resting excessively before and after activities. And when we assess John, he's also rating on a subclinical depression. He feels that despite all these efforts to control his symptoms, he has a recurrency of AF episodes. So he's sensing a sense of hopelessness. And so John has what we have decided to call symptom preoccupation in AF. We could also call it cardiac anxiety. We've also seen that some patients are not anxious, but more preoccupied, or they have also avoidance behavior, habitual avoidance behavior out of rules. So that's why we decided to call it symptom preoccupation and not cardiac anxiety, to be able to target a wider proportion of patients. But for John, he has fear of experiencing and triggering AF episodes. He has hypervigilance toward cardiac and AF-related symptoms, and a lot of AF-related avoidance behavior. And symptom preoccupation has been associated with higher self-reported symptom severity and low quality of life. And we know that these components have been targeted successfully by exposure-based CBT and other psychiatric and somatic conditions. So we thought that this clinical presentation suggests that exposure therapy could be an option for this patient group. But when we started this project, CBT had never been evaluated or tested for AF patients, even though there's a lot of literature on anxiety, depression, symptom preoccupation, etc. So exposure-based CBT aims to reduce avoidance behavior, fear of symptoms, and disability via systematic exposure to internal cues or avoided situations. And we also decided to develop the treatment so that it could be delivered via the internet in order to make it accessible and scalable. And internet-delivered CBT has shown similar results as in face-to-face CBT. So the overall aim was that we wanted to develop and evaluate an AF-specific internet-delivered CBT protocol for patients with symptomatic paroxysmal AF. And it's also worth to mention that this initiative came from the cardiologists at the Karolinska University Hospital that felt that they were not able to help their patients fully, despite giving them optimal medical care. And they contacted our research group, where we have done a lot of exposure-based treatments on other somatic conditions. So please feel free to interrupt if it's, or ask me if it goes too quickly here. So in order to figure out how to best treat these patients with CBT, we conducted a series of clinical studies. We started out with a face-to-face pilot study, and then we transferred the treatment to a pilot study over the internet. And after that, we evaluated the treatment protocol in a randomized controlled trial And we also conducted a mediation analysis on the data from the RCT to understand better how does the treatment work, what is actually happening, what is affecting the treatment outcome. And we wanted to build on the clinical and procedural experience and use this step-by-step method, since this had never been really done before. So in order to be eligible for the studies, all patients underwent a cardiac assessment by a cardiology nurse, cardiologist, as well as a psychological assessment. And the patients were diagnosed paroxysmal AF, confirmed by an ECG, and we wanted them to have a minimum of 1 episode per month, and that they experience their symptoms as troubling or causing limitations in daily activities. We also ensured that they had medical care according to current clinical guidelines, and that there were no other medical or psychiatric illness or medical restriction to be physical active, for example, as heart failure or other cardiac condition that would prevent us from conducting exposure exercises. And now I'm going to share some of the components of our final treatment protocol. So in the first module, we use a lot of education on AF, that the patient is well informed about the diagnosis, has been associated with positive outcome, and less negative attitudes around their medical condition. So thorough education on AF and its medical treatment, but also information on how to lead a healthy lifestyle, as well as how symptom preoccupation and avoidance behavior may affect physical and mental health. We also ask the patients to identify specific AF-related avoidance behavior, thoughts, etc. Then we proceed to interoceptive exposure exercises to reduce fear and hypervigilance of bodily symptoms or sensations similar to AF by engaging in physical exercises such as running on the spot, hyperventilating, or even just lying on the left side and feeling your heart. A lot of these patients, they don't even want to lie on the left side on the bed because they don't want to have any contact with the sensations from the heart. So we have about 8 different cardiac related interoceptive exposure exercises for the patients. And we encourage the patients to repeat exercises until the fear subside, or that they can tolerate these sensations. This also gives the patient, so it's like a paradoxical intervention, because a lot of our patients, they are monitoring and holding back a lot. And here we try to encourage them to provoke symptoms. Not AF episodes, but bodily sensations that have been conditioned with fear for the patient. And we also use labeling exercise or a self-observation exercise to both increase tolerance of bodily symptoms, but also willingly be able to focus on your heart or chest. Because for a lot of our patients, they either avoid their heart, or they're trying to distract, or they try to control it. So this is like a labeling exercise to increase the tolerance and willingly focus your attention inwards and then be able to let go and focus outwards. And we're also using this a lot while conducting exposure exercises. And then we proceed to in vivo exposure to avoided situations or activities where symptoms are unwanted. For example, to participate in a social activity while you have cardiac symptoms, or stay at work while you have an episode of AF, or while you fear of having it. And for our the case that I mentioned, where John, he would, for example, walk up the stairs at work and then hold a presentation while being able to observe what was happening in his body. So we often use these reduction of the control behaviors, and we use interoceptive and in vivo exposure exercises in conjunction to really enhance the experience. And then we also focus a lot on relapse prevention to handle the potential progression of AF, since we know it's a progressive disease, and for a lot of patients, the episodes will become more frequent. So also how to prevent to relapse into avoidance and control behaviors. For a lot of our patients, it's a control behavior to check the pulse. So we work to gradually postpone it 5 minutes, 10 minutes, 30 minutes, and then maybe expose yourself to the uncertainty of being in your body without controlling your pulse. And when it comes to internet-delivered CBT, it's text modules delivered online, and you have home assignments that you report to your treating psychologist. And usually we have contact with the patients about 3 times a week. So it really allows for good monitoring of the treatment progress, and you can give very quick feedback on exposure exercises and on the progress and answer questions. And also internet CBT increases access with a geographic reach. We had patients from all over Sweden, and it also reduced the therapist time. So you can have more patients in treatment at the same time. And during the internet delivered CBT, we also had great support from our study cardiologist. So if there were any questions about the patient's symptoms or medical concerns, we had support from our cardiologist that could help us. So we really ensured patient safety during these exposure exercises. And patients were also instructed to stop exercises if they had physical induced chest pain or faint, or they were feeling faint and so on. So they also got a lot of education on when to seek healthcare and when to stop the exercises. Here is an example of a behavioral checklist that we use in the internet platform. So even if they're standardized text and exercises, we try to make the treatment very idiosyncratic. So it's based on the patient's goals, behaviors, and what they would like to work with. So this is a way to plan, monitor, and follow up on exposure exercises. And you also report back, how did it go? What were my symptoms, levels of anxieties, and so on. We gave them a lot of feedback on how to plan and conduct the exercises. So I will now proceed. Let's check what time it is. Good. I will now proceed to talk a little bit more about the studies and how we developed the treatment. So we started out with a face-to-face pilot study just to test out the treatment strategies that we had in mind. And then based on the patient's clinical presentation and response to the different components, and they were also rating how valuable they felt that the different components were, we developed the first face-to-face treatment protocol. And we also wanted to see, is it feasible, acceptable, and is it even potentially effectiveness to use a CBT method with AFib patients? So we treated 19 patients in a face-to-face 10-week AF CBT at Karolinska University Hospital. We could see that the mean AF duration was about 8.3 years, and the mean age was around 60 years old. And the key result, the main outcome was AF-specific quality of life and AF symptoms. And we could see that over the 10-week treatment, there was a large improvement, within group improvement in AF-specific quality of life and symptoms. And the results were sustained 6 months after the treatment. So encouraged by this, we developed the treatment protocol and wanted to test the feasibility for the treatment over the internet. And after having conducted a lot of therapist-led exposure exercises, we were really trying to instruct the patient and support the patients to be able to conduct the interceptive exposure independently at home with support of the internet treatment. And we saw a similar improvement in increase in AF-specific quality of life and a reduction in symptom preoccupation, as demonstrated over the graph that shows the reduction in symptom preoccupation over the 10 weeks treatment. So after these two first pilot studies, we concluded that that patients showed high adherence and high satisfaction with the treatment, and that AF CBT helped them to deal more effectively with the AF symptoms. It increased quality of life among other outcomes, The results were sustained 6 months after the treatment, and the weekly adverse events that we had measured only showed very mild adverse events, such as stress or more increase in cardiac focus. So then we, encouraged by this, we proceeded to test the treatment protocol in an internet-delivered randomized control trial, where we included 127 patients from all over Sweden. They were either self-referred or referred by a cardiologist, and they underwent a cardiac assessment, psychological assessment at the Karolinska University Hospital. And patients were then randomized to either 10 weeks of therapist-guided internet-delivered CBT or to one module of AF education only, with no contact with a psychologist. And the wait list that was offered AF education were then later on crossed over to treatment. The primary endpoint was AF-specific quality of life 3 months after the treatment. And since we had seen very positive results in self-reported AF symptom severity and frequency, we were also intrigued to investigate the objective AF burden to see if we were to affect the underlying disease. We discussed this a lot in our group, and we had different views on this, if we were to affect, but maybe one part of us thought that maybe the anxiety-driven trigger of AF episodes could be affected by a treatment. So patients were, AF burden was measured by a 5-day continuous ECG recording at baseline, post-treatment, and a 3-month follow-up. Here were the sample. So 127 patients with a mean age of around 65. We had 58% that were female, and the AF duration was 6.1 years. Interestingly, we observed that about 24 to 29% had a diagnosable anxiety disorder or a depressive depression, whereas about 65% in the sample were diagnosed with somatic symptom disorder, which is a diagnosis where emotional and behavioral patterns or reactions to your somatic disease are the most prominent in the clinical picture, which for us further emphasized the focus on really targeting symptom preoccupation. So it's the cardiac related anxiety and avoidance behavior that is very prominent for this group. Here is the change in AF specific quality of life over the study period. And you can see the blue line is the CBT group. They improved with 21 points at 3 months follow-up, and the results were sustained and still significant at 12 months follow-up. So this yielded large between group effects, whereas the control group that received AF education only improved 6 points in AF specific quality of life. And when they later on were crossed over to treatment, we saw a similar trend. And these results in affect or AF specific quality of life, which is a well-validated measure that is used in medical trials as well. And we can see that the results of CBT are comparable to recent ablation trials and rate trials, which was very encouraging because CBT has less side effects, it's less invasive, and it can be more accessible for a larger group of people. In the other outcome measures, we also saw effects in symptom preoccupation, AF symptom frequency, and AF symptom severity, as well as general quality of life and depression between groups. And these secondary outcomes were also sustained 12 months after the treatment. We saw that AF-CBT led to a reduction in AF-specific healthcare utilization, and that the AF-CBT group saw 56% less healthcare. And when analyzing the objective AF burden, we saw no difference between the groups, but we at 3 months follow-up. But despite the lack of difference between the groups in objective AF burden, we still saw the large in-between group improvements of quality of life, symptom preoccupation, and self-reported AF symptoms. So this was very interesting to see. There's no difference, but still the psychological effect was still very large. Now, can you still hear me?
Yes.
Yes, good. Thank you. Thank you. It was some sound that stopped here. Okay. Well, so we knew that the treatment had shown effect, not in the objective AF burden, but we wanted to investigate psychological mediators to understand the underlying treatment process. So we used the weekly measurements that we had in the RCT over the treatment period of time. And we investigated cardiac-related fear and hypervigilance, avoidance, and perceived stress as a competing mediator of the treatment outcome. And we could see that the reduction in fear, hypervigilance, and avoidance had a mediating controlled effect on on self-rated AF symptoms and AF disability, but not perceived stress. And in order to see the order of a change, we used a time-lagged analysis of the within individual week-by-week change that demonstrated that a reduction in cardiac-related fear hypervigilance preceded a change in self-reported AF symptoms, and a reduction in avoidance preceded change in AF disability. These are constructs that a little bit goes hand in hand, so maybe that's not so surprising, but it was interesting to see that it was the fear and hypervigilance that preceded change in the self-reported AF symptoms. So to us, this really strengthened our treatment strategy and also demonstrated how psychological factors, fear and hypervigilance really affect the clinical course and how patients perceive their symptoms. In conclusion, we saw that AF-CBT significantly improved AF-specific quality of life in patients that already received routine care, that had received optimal medical treatment at inclusion, and that the results support a treatment strategy targeting symptom preoccupation, and that we think that AF-CBT delivered via the internet has the potential to improve well-being in a large group of patients, and that the data support an integration of psychological evaluation and treatment in an interdisciplinary approach to AF management. So in our first RCT, we used a little bit enhanced waitlist control in order to, since the treatment was so novel, but we are currently conducting a large scale RCT with 260 patients. We have about 100 included at this point, where we compare exposure-based internet-delivered AF-CBT versus stress management to control for specific treatment factors such as attention from caregiver and so on. So a credible stress intervention, which is also something that is often used in this patient group in Sweden at least. And we have also one PhD student that has used the treatment I developed and developed the protocol for ventricular extra beats, and he has completed one face-to-face pilot study. And we have also used the same exposure-based approach for patients with cardiac anxiety following myocardial infarction, where I have completed one pilot study and have one internet pilot ongoing. And the graph here shows reduction, the red line, reduction in cardiac anxiety and increased physical quality of life as measured by SF-12. And yeah, I'm also very excited to continue the collaboration with your center in our coming studies. I don't know if I should mention what that is about, or if that can be a later point. But thank you so much for listening and for your attention, and feel free to ask any questions.
Thank you, Josephine. That was a really wonderful talk. There was a ton of discussion going on in the background. Maybe I'll kind of use that to kind of guide I'm glad we have time left over to get at some of the discussion points.
Yeah.
So maybe I'll start at the top and work my way down. And of course, other people have questions along the way. Please jump in.
Absolutely.
Okay, where's the chat? Okay. Sorry, 1 second. So one of the first comments by Dr. Edmondson was, I'd love to see this protocol, very cool intervention, brilliant to develop it for atrial fibrillation, given the safety profile versus heart attack and stroke. So I think that comment's getting a little bit at safety concerns, and I'm wondering how your IRB, if they had any concerns with sort of internet delivery, how much cardiologist evaluation did they require, particularly as we do have some other protocols where we're asking patients to sort of exercise in conjunction with the behavioral intervention and in patients who have underlying cardiovascular disease, and just wondering how your team and IRB kind of navigated any safety concerns especially sort of run not by an MD type person.
Yeah, I think that's a very valid question when you work with somatically, this kind of somatic disorder. We used a thorough cardiac evaluation, both screening the medical charts, but also patient came to Karolinska University Hospital. We had an updated echocardiogram for them if the past 12 months, and if they didn't have one in the medical chart, we had an assistant conducting a new fresh echo, and we also took an ECG on all the patients before inclusion, and also going through the medical list to ensure that they had optimal medical care according to guidelines. So we had 2 cardiologists working with us, and one of them is also a PhD student in the project. So I think the thorough cardiac evaluation, along with the psychological evaluation to exclude patients with more severe psychiatric disorders, helped the ethical application along. I remember in our first ethical application, we really had to distinguish the interceptive exposure because we asked them to run on the spot and to hyperventilate. And they were a little bit confused that we wanted to trigger AF episodes. So we really had to distinguish that we wanted to provoke physical symptoms in order to reduce fear and hypervigilance. That I remember was one of the hiccups in our first studies. But other than that, with the medical evaluation, it has worked fine, and also the backup from the study cardiologist for us psychologists. And also the patients included in the study, their treating physicians still had their responsibility. So that was also clarified in the beginning, that we didn't take any medical treatment responsibility over the course of the study.
And were there any safety, you mentioned there were just sort of these transient adverse psychological effects in some of the patients. Were there any medical events that happened in any of these studies so far?
No, we didn't have any adverse medical or cardiac event. And our cardiologists say that, and we can see that in our table 1 for the RCT is soon to be published, we hope, but it's unpublished so far. But they see that the patients are extremely well treated and almost over-treated. So in that regard, also, if you have cardiac-related anxiety, you also self-refer or you're referred to a study. It's also a patient group that are, in our study at least, were very well treated. But in the in the first RCT, we had a medical evaluation on site. But in the large scale RCT with 260 patients, we are not seeing the patients. We are only using medical chart screening, and that has been approved. So we have two cardiologists and a nurse that are screening the medical charts for updated echocardiograms and ECGs and so on. So at this point, we don't even see them because we didn't observe any adverse events. And with the optimal medical, or the treatment as routine care, physical exercise should not confer any risk for these patients because we ensure they don't have heart failure or other underlying somatic diseases that are a contraindication to be physically active, but rather to be physically active is very good for this patient group. So we have also been writing in our ethical concerns around what the anxiety is preventing them from doing and what the CBT, the cost benefit, what CBT can actually help them to do. So I would say that our cardiologists are assessing the risk of participating in CBT as very, very minimal. Yeah.
Anyone else have safety questions before we jump on to the next comments? Another question I had sort of related as once we're talking about this was if you could tell us a little bit more about how recruitment worked out in reality. Like I saw that patients could sort of self-refer themselves, and then I guess you would check with their treating providers to make sure, but you also had cardiologists referring patients. And I'm wondering which approach was more successful and how did you get that to work?
So in our first two pilot studies, we had patients referred from tertiary care. But in reality, in Sweden, a lot of these patients are taken care of in primary care. So we missed a lot of patients there. And I also think from a cardiologist's point of view, it's hard to define who would benefit from a CBT treatment that had never been tested before, who has symptom preoccupation. So we saw that our cardiologists either sent us very psychiatric patients or patients that were not bothered by the heart. So the recruitment was very, very slow when we used the cardiology clinics in Stockholm and Sweden, despite holding lectures and sending out materials. So then we said, okay, let's do both. Let's have the patient self-identify. So for the larger scale RCT, it's also a question of funding and time and so on. And we wanted to test our protocol. So we opened up for advertising in social media, daily press, and to cardiology and primary care clinics. And boom, in one day, we had 80 patients that had self-referred themselves in our online system, where they fill in medical history and self-reading assessments and so on. And then we took the cardiac assessment in-house. So then we had the cardiologist in-house doing all the work. So then we were able to recruit and include the 127 patients in about a little bit over a year. So it was a large interest from the patients where they self-identified that I am very occupied and I feel that my arrhythmia is dictating my life and so on. So that was a learning process over the course of the studies.
Super interesting.
But of course, I think the reviewers will say, why didn't you use a consecutive recruitment from clinics and so on? But it's not a pharmacological trial that one size would fit all. It has to be a need, and the patients need to have an avoidance behavior or a fear in order for CBT to work and be motivated to participate in a 10-week treatment. So the treatment is for patients that are bothered by their arrhythmia. Might not be that we can generalize this to the whole AF population, but we think that a large proportion have this problem. And we have conducted a cross-sectional study just to see how large a proportion do have the symptom preoccupation pattern. But we're analyzing that data to be able to answer to that question as well.
Great. Another question we've had as a theme running through our center is the idea there's different dimensions of interoception. There's sort of the heightened distress you might feel from symptoms, but there's also the accuracy of detecting symptoms as being truly representing, an irregular heartbeat, for example. And I'm just wondering if you had any thoughts on how accurate patients were at what they were calling AF episodes. Like, it sounds like you had some objective monitoring in some of the studies.
Yeah.
And if did the inaccuracy go along with heightened distress, or those two different axes that weren't necessarily related? Just any, especially with nowadays, a lot of people have smartwatches that they can use to track the rhythm. And
yeah.
so I had
That's the first thing that we try to remove, take off the Apple Watch just during the course of the treatment. I would say exactly what you mentioned there with the heightened awareness and hypervigilance. Patients will misinterpret their symptoms. And that is also well known that AF patients both overestimate and underestimate their symptoms. And I think the objective data and the self-rated measurements and the gap shows that with reduced anxiety and reduced preoccupation with the heart and being able to do things or participate in life together with the arrhythmia, it's less of a threat to your life's integrity and so on. Patients described that they sensed less of their arrhythmia and even reported that I don't feel my AFib anymore. But I'm sure, I mean, we saw that the AF burden on a group level was the same. And we also saw that it was almost a significant increase at the long-term follow-up. I hope that was answering your question.
So would you, if let me see if I can reword it, would you say that some patients were overly over-reporting AF burden initially, and they reported less over time, and maybe were becoming more accurate as a result? Is that possible?
Yeah, I would say so.
Super
Definitely.
And it sounds like you asked people to take away to not use a smartwatch if they had one, at least for rhythm monitoring. Was that part of the intervention, or was it viewed as contributing to the distress?
We also saw that constantly keeping track on your rhythm became an excessive safety-seeking or control behavior. So for a lot of the patients also to tolerate the uncertainty, do I have an arrhythmia, or what am I feeling? Because a lot of the focus would be, is it AFib? Is it just stress? What am I feeling? Okay, should I stop what I'm doing? So yeah, to be able to work out without having the Apple Watch on, or postpone pulse checking and increase the tolerance for bodily signals, that would absolutely be part of the exposure exercises.
That's really interesting, because we've definitely heard that in, I think I saw Samantha Ferris on here somewhere, but that's something we've heard about in some of our other people working on these types of interventions. I'm not sure if they want to say anything about that, not to put them on the spot.
Happy to speak to it. I'm off camera, but I can be less obscure. This is really wonderful, Josephine. Really wonderful to listen to your research, and we're doing similar work in New Jersey as well, with patients in cardiac rehabilitation. And so they have a bit more comorbidities, but we actually directly, to Ian's point, we directly target safety behaviors related to checking pulse or relying on telemetry monitoring during exercise for that extra sense of safety. So we directly target it and actually use the watch, the activity watch, as a kind of a behavioral experiment or an opportunity to test out, how does your anxiety change from excessive monitoring versus without, and is the intolerance of uncertainty kind of rises without that feedback, what happens to it after that acute rise, and can you tolerate that and sit with the discomfort? So really, I'll definitely be following up with you in email, but the safety behaviors are directly targeted in a lot of our work, and it sounds like you're absolutely targeting that as well.
Yeah, that sounds very similar to how we worked with those kinds of safety behaviors. Definitely. Thanks for your input.
I've been hogging the conversations. If people want us to jump in line with their questions, please do. Otherwise, I'll kind of go back to the comments. Does anybody have anything that they want to ask before we go back to the chat? Okay, so some other comments about the combination of in vivo and sort of actual physical activity, the sort of guided exercise. Could maybe you could tell us a little bit more about some, I don't know if there are anecdotes around the sort of in vivo exposure and
in
how
combination with interoceptive exposure.
Yeah, like which was more important, or how, I don't if you have any thoughts on, or do you need both of them? Is the in vivo really a crucial piece, or just curious your thoughts on that?
That would be a very interesting dismantling study to test if it would be in vivo or interoceptive. I would say the interoceptive exposure was crucial in order to give a signal to the patients you are allowed to use your body, and also under controlled forms provoke physical symptoms, and refrain from controlling them, but just let them come and pass and observe them. The in vivo, some patients didn't have a lot of overt avoidance behavior, but a lot of worrying and focusing and constantly monitoring. So for them, I think the interoceptive exposure was very important, as well as the observing the heart exercise. Other patients would have very overt avoidance behavior, much like patients with agoraphobia and panic disorder. I wouldn't go on the train. What if I have an AF episode? I don't want to be at the dinner party. This feels very shameful for me. I don't want people to think of me as a heart patient. So there were all different kinds of anxiety related. And some patients just were very occupied by monitoring, checking, and adapting their behavior or rhythm of walking or so on. So you really have to find what the maintaining mechanism is for each patient. But many times we used, for example, hyperventilating before going to a dinner in order to be able to trigger the heart to take the stairs to the dinner party, or being able to tolerate your physical symptoms while being in a situation where you fear of getting an AF episode. So run a little bit before you get on the train or so on. And that is creating an over-learning experience. Maybe you won't do that after the treatment, but this is creating an experience where you, with our support, we're able to deal and tolerate, and also with the uncertainty. I would also say, starting to working with these patients, I felt a lot of cardiac anxiety myself, because we started with therapist-led exposure exercises. We were running up and down stairs, a little bit older patients at the cardiology clinic, and you'd feel like, okay, I'm not only just triggering the anxiety here, but it could trigger an AF episode. So that was like a parallel process of deal with their own uncertainty. But we also framed the AF episode as a way to practice the acquired skills. So we said, okay, we don't know when AF will come, because a lot of patients keep long Excel lists of exactly when and how and different triggers. So it's also to be able to accept that it comes and goes. You can't control it. You can't blame yourself for having an AF episode. And when you increase your heart rate by running on the spot or doing this, might happen. But if you'll get an AF episode, it's a perfect opportunity to continue with your plans, observe your heart, continue with your life, and practice what we've talked about during the treatment. So that was also a way of accepting symptoms come and go. How would you like to lead your life? But also as a therapist to accept that we can't control their arrhythmia episodes. But we know if they have treatment, they should be able to lead a normal life, be physically active, and the arrhythmia itself is not dangerous.
Can you remind us what percentage of patients dropped out after, did they find it too distressful that they did one session and then?
We had about, I think the exact number, I have my dissertation here for but I think we had about 88% that completed the full treatment.
Oh.
So I think that in the face-to-face one, all of them completed the treatment, but then you have really hands-on support. But the internet delivered method, you can also do it at your own pace, you do it at home, you can read on your cell phone, on your iPad or your computer or your phone. And also the communication with the therapist, you could get a lot of support if needed, and also we really try to adapt the treatment to the individual, to fit the goals and the behavioral repertoire of the specific patient. So I would say we had that's a little bit higher than I think in normal internet CBT. I think there is a completion rate about 60%. So we had a very high adherence, but I also think it's it's motivated patients with a thorough treatment assessment. And if you've gone through the cardiology assessment and psychology, it was also maybe that we got very highly motivated patients.
I see another question from Samantha, which I think other people maybe had also, was how did you do the interoceptive exposure exercises in terms of remotely? Like, did someone have their Zoom camera on while they were doing it, or did they do it on their own and then just write back and forth, or how did it actually operationalize?
Yeah. So first we have a full module on reading on why it is a good idea to expose yourself to physical symptoms with case examples, and this patient worked with this like this, or this is what it's going to lead to. And then we had the 8 exercises very well written, and make sure that you talk to your treating psychologist. If you have any hesitance, we know that it's very common that you want to postpone it, and this is anxiety provoking. But we also encourage the patients to use a spouse or a friend or a co-therapist at home to help them, and also to grade the exercises. Start with 30 seconds, then try 40 seconds, and so on. So I would say that it was all written, and then they wrote back to us on a worksheet. How did it go? What was the anxiety levels? What kind of symptoms did I experience? So this exercise started in module 3, and then it continued over the 7 weeks that were going. So they worked with the different exercises until they rated the anxiety level or fear level or discomfort level below 20 on a 0 to 100 scale. So all text-based, but we worked a lot trying to make this happen. And I would say in our second pilot study, I had maybe 12 exercises. It was a module where a lot of patients got stuck. So this is also something I adapted and streamlined for the RCT, to have fewer exercises and a lot of encouragement. But we also had like warning texts. So if you do it, these are the symptoms that you should be aware of. This is where you stop, and so on. So I think, yeah, it was a learning. Yeah.
With the instrument delivered, did the therapist ever sort of meet the patient like on a Zoom, or was it only asynchronous communication through like text or email? Text. Wow. Okay.
Yeah. It's only interactive modules and then text-based via messaging.
Was there one therapist for everybody, or would the same therapist follow the same patient through, or it could be different therapists depending who was sort of on call that day?
Oh, you have the same patient throughout the whole. And when I started this, I had worked for a couple of years as a clinical psychologist, and I was just like, okay, how's this going to work over the internet? So in Sweden, it's a lot of the clinical research is done via internet CBT, but you really form a relationship and a good alliance with the patients. You have even a closer contact with them. So I would say that I've been very positively. I love internet treatment, and I feel very connected to my patients that I have in internet treatment. But on the RCT, we were 5 clinical psychologists working, so we wouldn't have one therapist effect. So we were 5 psychologists that had all got training in AFib, and that got weekly supervision from me and my supervisor.
One thing I noticed is that your population was similar age as what we would expect. I think the mean age was around 65. So they include a lot of older adults who are still capable of doing this sort of technology-driven approach. So it's really amazing that it worked out for that patient group.
Yeah. So it's very basic computer skills. It's basically like sending an email and opening a text-based module. I'd be really happy to to show you what it looks like. And actually the internet platform is currently being used at Yale in an internet CBT study. So I'd be happy to show you what it looks like inside. And it's a very great treatment platform, but also to collect data and follow the treatment progress via graphs and so on. So it's been developed here by one of my advisors on the project, and it's widely used in Sweden and even internationally.
Do you have any, that was actually one of my closing questions, but do you have any sense on sort of dissemination? Is it, why is it being used in clinical practice or more as part of other research protocols? Any thoughts where?
The internet CBT, yeah, we actually in Sweden, we have with the same platform that we're using in the clinical studies, we have an internet psychiatry unit treating common mental disorders nationally in Sweden. But as far as goes for the AFCBT, we're waiting to see if the treatment is still stays strong in a like gold standard RCT with an active control group. And then we really hope to disseminate it via an internet treatment from Karolinska University Hospital, where we could have like a centralized expertise in AFCBT with the cardiologist on board, and hopefully be able to treat patients nationally. So that we really hope that we can implement the treatment in routine care as a treatment option or as an add-on option for AF patients.
And is there a pathway for that to be something that's sort of covered by standard health insurance? Like with the therapist time could be, yeah, sort of paid for, or something that someone would pay out of pocket for to get the CBT?
That would, if it would be part of the routine care, it would be the same patient cost as if you sought normal care. And one upside is that healthcare is free in Sweden. So if we were to implement it in a healthcare system, we could reach a large proportion of the AF patients.
Well, that is mind-blowing compared to the context in North America or the United States. Super exciting that there's that potential for scaling up these psychological approaches. I think we just have a minute or two left, so I just want to leave open a chance for one other question from someone in the audience. So I think with Josephine's permission, we can try to circulate some of her papers that are already published, and if people have direct questions, I'm sure she's open to be emailed directly. So
absolutely.
Make sure. And yeah, super excited that we're going to be able to continue to work together through the Roybal mechanism. And thank you so much for presenting today. It's really, really exciting work. And I think we also love the fact that it really went methodically from sort of really proof of concept feasibility studies all the way to sort of testing the mechanisms and sort of going to a larger scale, attention controlled RCT, and already thinking ahead to sort of implementation and scalability considerations. It's really, really an amazing body of work.
Thank you so much. Thank you so much for having me. And I'm super excited for this upcoming opportunity and to get to know all of you a little bit better and to collaborate. I think I can learn a lot from your group as well.
Great. Thank you so much, Justine. And thank you everyone for joining. It's really great to see everyone together.
Yeah.
Wish everyone
Thank you for joining.
Good day. Yep.
Bye, okay. Everyone. Bye.